Okay.
Okay. Professor Strydom, we are pleased to welcome you as an invited speaker at the 13th EAMHID Congress 2021 in Berlin. You will give a keynote lecture about Alzheimer's disease and Down syndrome, from understanding pathology to prevention, which fits well in our Congress topic, from science to practice, improving mental health in persons with intellectual disability. My first question, please allow me a personal question. How did you get involved with the topic intellectual disability during your medical and academic career?
So thank you. Thanks for the invitation to deliver the keynote in the first instance. But yes, well, there's many years ago that I finished training in medicine, and initially I was interested in internal medicine, specifically oncology, but became interested in psychological and psychiatric aspects of people's presentation, of clinical presentations, during a placement in palliative care. During oncology training, and there we had a liaison psychiatrist attending our case discussions, and I could see the impact their input had in our management. And so I decided to switch to psychiatry, but maintained an interest in physical health. And I think intellectual disability psychiatry offered me the best of two worlds. So it's where you have to combine both training in mental health and physical health issues for a more holistic approach to patient care.
I can understand that very well, because a lot of my colleagues are not only psychiatrists, but also neurologists, and we really appreciate the possibility to look over and see more than just the small, not small, but just the interesting field on psychiatry. So I can understand it very well. It applies to a lot of my colleagues as well. Thank you. And this leads me to my next question. Your research interest focuses on age-related issues in ID, such as Alzheimer's disease and Down syndrome. And why did you specialize in aging and age-related disorders in ID?
Well, yes. Well, in the UK, I should explain how psychiatry training works. So we do generally 2 or 3 years for sort of general or basic training in psychiatry, before then selecting a specialist area and doing another 3 years of training in a specialist area. So my first general training placement in a training program when I switched to psychiatry was in geriatric or old age psychiatry. And I found that very interesting. And so when I started my specialist training in intellectual disabilities psychiatry a few years later, I became involved in setting up a memory clinic, one of the first memory clinics for people with intellectual disabilities. So bringing some of my interest in old age psychiatry together with ID psychiatry. We did that with one of my trainers. And most of the people, of course, we saw in that clinic had Down syndrome. And so I've been involved in dementia clinics for people with intellectual disability and Down syndrome ever since, in addition to, you know, offering other sort of inputs to people with other mental health conditions, of course, with intellectual disability. And that has also developed into my main research interest.
And how many years are you doing this?
Gosh, so we start. So it was in the late 1990s, I think, that we started the memory clinic, or evaluated the first memory clinic. So it's 20 years, something like that.
It's a really long time. Okay, so can you remember a special case that caught your interest in this field?
Yeah, there's so many, but I suppose one person that often sticks to my mind, that I often remember, also because he was a sort of a model, I suppose, for one of the Down syndrome support organizations. So he was the person on front of their literature, and I still see pictures of him on the internet sometimes, even though he died quite a few years ago. But he was a man with mosaic trisomy 21, so mosaic Down syndrome, and he lived to quite an advanced age. So we only started seeing him for some concerns, some cognitive concerns, when he was already in his late 60s, which is relatively old for a person with Down syndrome. And he was still at that time living independently in his own flat with his wife. He was married and had support from supporters coming in, but only for a certain number of hours a day. And I suppose that showed that many people can maintain good levels of functioning well into older age. But it also showed or reminded me of perhaps the potential impact of genetic risk factors. So in his case, because he had mosaic Down syndrome, he was less likely perhaps to develop Alzheimer's disease at the same age as some other people, the early ages that we see in some other people with Down syndrome. We still need to understand the impact of mosaic trisomy 21 compared to full trisomy 21 at a genetic level, but nevertheless, there are some indications that it may be slightly protective in some ways.
That's really interesting. I think I should read a little bit about this topic. That's really interesting. Never
Yeah, I
heard
don't
it
know if there's
before.
much out there, but
Yeah,
theoretically,
I've never heard it before. It's good.
it should, in some people at least, be
Yeah.
somewhat protective.
Okay. Can I ask you another question? From your point of view, what do you believe to be the most important recent paper addressing dementia in ID?
Well, I always have to think back of some of the older papers, and one of my research heroes is and was Helene Evenhuis in the Netherlands, who did quite a lot of work trying to understand the epidemiology of Alzheimer's disease and aging-related issues in not just in Down syndrome, but other people with intellectual disability, impact of sensory impairments. So I still go back to some of her papers sometimes. And equally, Mary McCarran in Ireland is continuing to do some amazing work following people over a very long period of time, 20, 25 years now, one of her groups of people with Down syndrome, which really helps us to understand and estimate the risk, the ultimate risk for Alzheimer's disease in people with Down syndrome.
Yeah.
More recently, however, there's been lots of work to apply new technologies and understand the development of Alzheimer's pathology in living people with Down syndrome. And so some of the interesting papers and work has been done by Shahid Zaman and Tony Holland on amyloid PET imaging, as well as Juan Fortea in Barcelona and their work on a range of biomarkers for Alzheimer's disease in people with Down syndrome. And I think in the near future, we should see a lot of work coming out from the ABCDS study groups in the US. So they have been collecting data on several hundred people with Down syndrome, doing very intensive workups and phenotyping, and so there will be lots of work coming out from those groups, which would have potential for considerable impact, I think.
Ah, thank you. So we can look forward for these interesting papers.
Yeah.
Yeah. The topic of your presentation is Alzheimer's disease and Down syndrome, from understanding pathology to prevention. What has to be done in the field of prevention in daily practice, and how does this relate to the pathology of the disease?
Yeah, that's an interesting question. In a way, that's the $1 million question, I suppose. Yeah. The problem for us is that in terms of daily practice, there's not much to base our practice on. There's not been any kind of hugely successful treatments that we can apply in daily practice. But what we do in clinic is we always emphasize the need to maintain function for as long as possible.
Yeah.
And to continue to support the person to participate in meaningful activities, because that that supports their ongoing, it maintains function by building on cognitive reserve and building physical strength as well.
Yeah.
So we try and keep people as active as possible, of course, adjusting for their needs. And also, of course, it's important to minimize other risk factors such as cardiovascular risk issues. If those are present, you can do something about that. You can treat certain risk factors and diabetes and so on. And I suppose in people with Down syndrome who often develop seizures as dementia progresses, you can treat the seizures as well. And we find that we get good response with anti-epileptic treatments and can maintain ability for a bit longer. In terms of the future, there is much scope for potential intervention for Alzheimer's disease, particularly in Down syndrome, now that we understand the underlying pathology. So we know that people with Down syndrome have triplication of the amyloid precursor protein. And so we have a clear target for intervention. So the amyloid sort of pathway, or cascade as it is also called, it seems as if that is the most logical pathological process to target in people with Down syndrome. And in the past 10 years or so, there's been a lot of work in our lab and other labs on the sequence of cognitive changes and biomarker changes in the sort of the prodromal stages of Alzheimer's disease. In other words, before the diagnosis of dementia, the early stages of Alzheimer's disease. And all of that work, I think, will help us to undertake clinical trials of potential treatments. And so I have a lot of hope for the future for the treatment of Alzheimer's disease, particularly in high-risk groups such as people with Down syndrome.
Thank you for your very wide answer to my question. So I'm now hesitating to ask you my sixth question, because I think you said it at all. So I will continue to number 7. Can you tell us a little about your current research interests and what you are working on at the moment?
Yes, so we're continuing to work on biomarkers of Alzheimer's disease in people with in Down syndrome, particularly more, I suppose, practical biomarkers such as plasma biomarkers. So I think that some of the biomarkers, including CSF, doing lumbar punctures to obtain CSF, it's not feasible in many people with intellectual disability. Even imaging is difficult in many people with intellectual disability. So we need to look at other ways to bring forward the diagnosis and to use as biomarkers for treatment trials. And so we're very interested in plasma biomarkers, both of amyloid and tau. And also markers of neurodegeneration, such as neurofilament light. So we've done some work in that area, and we have ongoing work. We also think that we need to improve cognitive outcome measures and functional outcome measures for in readiness for trials, clinical trials. So we need outcome measures that are reliable, that don't have significant floor effects when applied to people with intellectual disability, and which can track change. So you can see change or improvement or decline when we do clinical trials. So we have, we're doing quite a lot of work in that area at the moment, and including redeveloping or refining the CAMCOG battery. So we are currently validating what we call the CAMCOG DS2, so the new version of the CAMCOG across several sites in Europe. And finally, so I think there's much more work to be done to understand other risk factors. So it's one thing to talk about the genetic risk, but what about some of the other risk factors that may contribute to decline in older people with Down syndrome and with other intellectual disabilities? And there we need to understand the impact of cerebrovascular disease, of cardiac risk factors, and of modifiable risk factors as well, diet, exercise, and so on. So that's another area of interest.
This is a this is a great variety what you are doing. I'm
Maybe.
really I'm really impressed what you are doing. Wow. And imagine you would get €1 million for research. What study would you like to do?
Well, yeah, that's a good question. I wish I had €1 million now in some of these things that we do. So, I mean, €1 million is not enough to run a clinical trial. So I would say, for me, the priority should be to develop a clinical trial-ready cohort of people with Down syndrome. In other words, recruit people with Down syndrome into a study that will follow them up, track cognitive change over time, so older adults, and sets a number of sites up to do this, and then be ready to run clinical trials on new treatments, amyloid targeting treatments or other treatments as they come through, so that we can make rapid progress in this area. So that's what I would focus on. In fact, we have plans to do this. So we have what is called the Horizon 21 cohort with several sites across Europe, and have already started setting up a trial cohort such as this, and €1 million will make a big difference. So if there's any funders out there, we are here, we're waiting to speak to you.
Thank you very much. I have no questions left. So thanks, Professor Strydom, for this interview. And we are looking forward to meet you in Berlin in September 2021.
Fingers crossed that there will be no issues with COVID and everything. Yes, yeah, we look forward to meet everybody there.